When two diseases meet, flu and COVID-19 will share at least one season. My name is Bara Vaida. I am the core topic leader on infectious diseases for the AHCJ. And a twindemic is what infectious disease experts are calling the possibility that both COVID-19 and influenza viruses will be sickening Americans this winter. How likely is that possibility? As of early November, the CDC says that overall seasonal influenza activity in the U.S. remains low, but there may be some early signs that a twindemic is emerging. There's one region, Iowa, Kansas, Missouri, Nebraska, where the number of cases is slightly higher than normal. So our distinguished panel here will shed some light on this and how we can approach our coverage about this coming flu season and COVID, how the healthcare system will handle the influx of COVID-19 and flu patients, and how the flu and COVID-19 is disproportionately impacting Black, Latino, and other vulnerable communities. And they will offer some insights about maybe flu vaccination rates and what that might mean in terms of a prism to think about COVID-19 vaccine in 2021. The first person who will speak is Dr. Virginia Banks. She's an infectious disease specialist with Northeast Ohio Infectious Disease Associates in Youngstown, Ohio. And she will talk about what we know about flu so far and what she's seeing in her area and social determinants of health and how that we see that play out with the flu. Dr. Lisa Margakis, she is an associate professor of medicine and epidemiology at Johns Hopkins University, and she is going to be talking about what we know about what we nationwide, the flu season and what the expectations are, and where we might be starting to see a twindemic happening and what that means for hospitalizations and surge and kind of the science of this. And our next speaker will be Lichen El-Jaitan, and he's the Chief Strategy Officer at the Immunization Action Coalition, and he'll be talking about how the healthcare community and public health officials are trying to get the message out there about both flu and COVID-19, and again, what this means for the COVID-19 vaccination process that will be hopefully happening beginning next year. So we'll start with Dr. Banks. I'm going to kick it off to you. Thank you.
Thank you. Thank you very much. Good afternoon, everybody, and thank you very much for having me. My name is Virginia Banks, and as Bara stated, I'm from Youngstown, Ohio. Just to start off, what are we seeing now? I think we're seeing what you're hearing about in the news and on different types of media outlets, a surge. I think we started to notice it a little bit, maybe the end of August, really, when we started to see an influx of more patients with COVID. And we were really sort of down at the end of July to maybe one or two patients in the hospital, and it's just continued to get worse. And we're not even really in high influenza season. So that's kind of what we're seeing here in Ohio, and it sort of reflects our governor came on this afternoon, and he's implementing more actually a curfew that's going to be implemented on Thursday. So I think what's happening here in Ohio reflects what's going on in the United States. So today I'm going to talk just a little bit about COVID and influenza and disparities. Next slide. Next, thank you. So I'm probably the elder statesman in this room, in this group, and I reflect where we are in 2020. When I started infectious diseases, went into my infectious disease fellowship at University Hospitals of Cleveland, many, many years ago, somebody came up to me and they said, well, you won't have a job because everybody knows how to use ampicillin and penicillin. And at that time, infectious diseases was a relatively new subspecialty. So here we are in 2020. Each year, influenza poses a substantial burden on communities and healthcare systems. And in most recent influenza seasons, influenza is estimated to have been associated with 29 million to 45 million illnesses. There have been, let me just preface this by the data that I'm going to be giving you on about the next 8 or 9 slides comes from an article that was written for the American Medical Association by Leandris LaBird, who's from the Center for Disease Control, whom I know, and Dr. Robert Redfield. and I've been given permission to disclose this paper with you. So a lot of this information is old, and I will kind of update you as to where we are, particularly with COVID. So 490 to 810 plus hospitalizations and 34,000 to 200 to 61,000 deaths each season in the United States. As of August the 17th, this is August the 17th, and I'll give you the updated data. SARS-CoV has been associated with more than 5.3 million infections and more than 168,000 deaths in the United States. The most recent information that I acquired yesterday shows that we are at 10,984,398 infections and 245,470 deaths. Next slide. So even a moderately severe influenza season in the presence of circulating COVID-19 would significantly amplify cases of acute respiratory illness and more intense the stressed healthcare personnel and resources that we're seeing here, even in our city, including hospital emergency departments, outpatient departments, and physician offices. However, less than half of United States adults even receive an influenza vaccine each year. Even after the severe 2017-2018 influenza season, the overall vaccine coverage remained at about 45% during the subsequent 2018 to 2019 season, and long-standing substantial disparities, particularly race and ethnicity, persisted in estimated coverage. Next slide. Vaccine coverage estimates remain substantially lower for non-Hispanic Black, Hispanic, and American Indian and Alaska Native individuals. And they have had the lowest influenza vaccination coverage and also have been disproportionately affected by COVID-19. I believe it was at the end of April that Dr. Fauci made the comment that COVID has shined a light on an unacceptable situation with respect to healthcare disparities in this country. And I can tell you, having been on the front line, the forefront of this disease in late March, when we started to see patients come into the hospital, even as an African American, I did not, really was not looking at race and ethnicity in terms of our patients. We were just trying to keep our patients alive. They were coming in so fast and furious. This was a new disease. We didn't know about treatment. So it really wasn't until the end of April that I was doing a symposium for the National Association of Black Journalists that someone asked me, had I heard that there was a disproportionate representation of African Americans and Latinx population with respect to COVID, and I said no, and they pointed to me, I think one of the first papers on this that came out of Milwaukee. So Cdc Surveillance Data through May 2020, and where they just looked at 1,320,488 cases, persons diagnosed with COVID for whom race and ethnicity were known. 33% were Hispanic, 22% were Black, and 1.3% were American Indian, Alaska Native individuals. But these groups comprise only 18%, 13%, and 0.85% of the United States population. Next slide, please. So these are just some graphs from the Kaiser Foundation showing influenza vaccination rates among non-elderly adults by race and ethnicity. And you can just sort of see here, just eyeballing this, the patients who are private, patients who have Medicaid and other public insurances, and uninsured. And the African-American population and the Latinx population is certainly lower than the others. Next slide, please. Again, influenza vaccination rates among adults and children by race and ethnicity, looking at adults and children. This is for the 2018-2019 season. Again, for adults, 39% Black, 37% for the Hispanic Latinx population. And for children, a little bit better, 60% and Hispanic. And of course, with children, there's more of an influence of the parents getting them to get their vaccination in the first place than adults. Next slide. So influenza vaccines will be a critical intervention in this effort. they are a critical intervention in this effort. And influenza vaccine effectiveness varies depending on factors such as the recipient's age and health, and the match between the viruses represented in the vaccine and the ones that circulate in the community. Even in a season of suboptimal match and low vaccine effectiveness, vaccination results in a substantial reduction in the burden of illness and the strain in the healthcare system. So vaccination is estimated to have prevented 7.1 million illnesses, 3.7 million medical visits, 109,000 hospitalizations, and 8,000 deaths in the United States. Next slide. So what are some of the reasons as we've been able to step back and look at this? And there have been lots of papers written about this now. I've done lots of webinars and symposia about looking at disparities. I guess you sort of have to look at, these disparities that we're looking at that affect COVID are healthcare disparities that have existed for a long time. And it probably should be no surprise to anybody that looking at a disease like COVID-19, that we would be here again looking at disparities with respect to this disease. And so they're multifactorial. So there are barriers to obtaining affordable, high-quality health care, including limited access to health insurance, transportation, and child care. And I stand to be corrected because everything changes on the dime, but I believe that there are about 14 southern states that have not done Medicaid expansion, which again speaks to, limited access for insurance for these individuals. And these southern states, again, are where there are some of the largest population of African Americans and Latinx populations. So again, barriers to adequate health care. Barriers to routine medical care mean fewer opportunities to benefit from preventive interventions and increased vulnerability to chronic conditions such as cardiovascular disease, pulmonary disease, and diabetes that are also associated with worse outcomes in both influenza and COVID-19. And what we know now as another major independent risk factor for COVID-19 is obesity. And we know that in the African American population and the Latinx population, that is a significant problem. Next slide. I guess this is probably, as I query my acquaintances, my friends, I'm involved in several African American organizations. I'm co-chair of the COVID task force of a large organization of African American women. I belong to the National Medical Association. And I guess this is probably the biggest thing that I hear from even those that are less well-educated and even those that are well-educated. The distrust of the medical care system, which may be more prevalent among members of racial and ethnic minority populations due to a history of discrimination and past instances of medical experimentation. Many people, again, reference the Tuskegee syphilis experiment that started in the 1930s and really didn't end until 1972. There's a eugenics program that occurred in North Carolina that was a problem. So it's not like the United States hasn't had a history. So again, that's a major problem when we're talking about rolling out a new vaccine with respect to COVID-19. There are other exacerbating factors, including inequities in education, employment, income, paid sick leave, and housing that make for increased difficulty with basic but critical self-care actions such as getting adequate rest and proper nutrition, as well as those important in keeping yourself, family, and community health during a pandemic, such as staying at home from work when ill. For example, a lot of the individuals who were essential workers belonged to the minority population. People living in multi-generational households couldn't quarantine. We all didn't have the luxury. Many didn't have the luxury, especially in those multi-generational households and other households, to separate, to self-quarantine. I remember watching Chris Cuomo on CNN and was trying to think about how I might do that. Might be impossible. Those things that I mentioned in that second paragraph, talking about inequities in education, employment, income, and so forth, all point to issues of structural racism. And I think when we start talking about vaccine rollout with a new vaccine called for COVID-19, that we have to start from basics and look at those situations in this country that have contributed to structural racism, which rolls down to healthcare disparities. Next slide. So until a safe and effective vaccine is available, now we heard some really good news this week from Moderna and Pfizer, and the majority of the population is vaccinated. COVID-19 cases and associated morbidity and mortality will likely continue. And without interventions targeting minorities and additional research on social determinants of vaccine acceptance and coverage, racial and ethnic minority populations are likely to continue to bear a disproportionate burden of both influenza and COVID-19. Next slide. So physicians and other healthcare professionals can make better use of tools that are already available. Basically, get your patients vaccinated for influenza. Every time a patient comes into your office or clinic, it's an opportunity for a vaccination. These vaccinations will neither directly reduce the effects of COVID-19 nor repair systemic societal issues that result in some populations having greater vulnerability to illness and poor health, but they will help. Next slide. So increasing influenza vaccination will help lessen the compounding illness and healthcare system stress caused by the additional circulation of another potentially life-threatening viral respiratory disease. As I said, we're seeing a surge here, and it's not even peak influenza season. What happens when we have these patients coming in with the twindemics that have symptoms that are similar? So we're encouraging that the influenza vaccine obviously be recommended to all patients. There's a national strategy that's on now on prioritizing measures to help reduce the disproportionate effect of these illnesses on racial and ethnic minority populations, partnering with organizations trusted by the racial and ethnic minority community. That's where I have been involved in a lot of minority organizations in the United States and helping the message. I think what's important in the rollout of this vaccine is that you're going to have to be very careful about who the messenger is delivering the message. Ensure full and equal access to influenza vaccination. And again, this article was written the article that I'm referencing was written for the American Medical Association, addressing influenza vaccination disparities during the COVID-19 pandemic by Grosskopf, LeBird, and Redfield et al. Next slide. So what are CDC doing? Well, they're engaging with partners in developing customized outreach to racial and ethnic minority communities to increase flu vaccination rates this year and every year, including developing culturally specific, like they did for HIV/AIDS, culturally specific messaging and linguistically tailored content to reach additional audiences. They're providing additional funding to state immunization programs to plan and implement flu vaccination programs. At least this was what was felt to have been done in August. I have to preface everything about what's happening today, November the 17th, 2020, with a focus on priority groups such as the non-Hispanic, Black, and Hispanic or Latino populations. Next slide, please. So lastly, this is one of the infographics from the CDC. And those of you will remember, especially with HIV/AIDS, that there were many infographics that were targeted, that were culturally specific, and I think that really helped a lot. And also now with PrEP, there are a lot of culturally sensitive messaging infographics that are out there for PrEP as well, which again is disproportionate, where the access is disproportionately represented. I am going to end here and toss the baton.
Okay. Thank you so much for that great perspective. I really appreciate that. I just wanted to, I didn't note this at the beginning of my introduction, there is, for everyone who's on this panel, there is a box below the speakers and presentation for audience to type in questions. And so I'll see those questions. We'll ask them after all the panelists talk. And we've already gotten one question, so please keep them coming. All right, thank you so much. Next, Dr. Margakis, go ahead, get on.
Sure. Thank you, Bara. Thank you so much for inviting me to be part of this panel. It's such an important time to share this crucial information as we head into the influenza and respiratory virus season, and we are already, unfortunately, in the midst of such a devastating surge of COVID-19. So that's the title of this panel, Twindemic, and I'll talk a bit about the implications for this respiratory virus season on the fact that we are already experiencing such surges of COVID-19 and what we anticipate this means as we head into respiratory virus season, where every year we see cases of not only influenza, but also other respiratory viruses that co-circulate and cause thousands of illnesses every year. So just to start with influenza, because often we refer to this time between mid-October each year to the following May as the respiratory virus season or the flu season. And for influenza, which is caused by any one of a family of influenza viruses, primarily influenza A and influenza B, they cause over 38 million illnesses in this country each year. And just to give you an idea of the scope on the medical infrastructure, that results in, at least last season, 18 million visits to clinics or emergency departments and over 400,000 hospitalizations. So this is a burden not only to individual patients who become ill with these respiratory illnesses, but also to the healthcare system that needs to absorb that surge of patients who need medical care, either in the outpatient setting or in the inpatient hospitalizations. And in a given flu season, a hospital, if it is a bad flu season, can have significant impacts on their bed availability, their staffing, and this can impact the care of other patients who are in the hospital for non-respiratory causes, so routine medical care and other illnesses. So if that's the landscape in a given respiratory virus season, you can imagine how concerned we all are as we are heading into that already, not only in a pandemic where we have the extra burden of illness that has been caused by the SARS-CoV-2 virus circulating really now across the country. Not only do we have that, but we have a really large surge, really simultaneously across the country in almost every state. And so we're seeing unprecedented levels, even higher than what was seen in the spring. And we're going to overlay that on top of the usual flu season. And I keep saying respiratory virus season because flu is not the only respiratory virus that circulates in the fall and winter months. We also have respiratory syncytial virus and a number of other respiratory viruses that can cause severe illness and hospitalizations, even death, particularly among the most vulnerable populations who have extremes of age or underlying medical conditions, particularly if their immune systems are suppressed either by medications or underlying medical illness. So that's really the concern. We know what happens every year. This year, on top of it, we have the pandemic. In addition, I need to mention that there is a significant overlap in symptoms. And we deal with this every year, trying to distinguish who has influenza, who has respiratory syncytial virus. And you might ask, why does it matter? Why does it matter which respiratory virus is causing someone to be miserable? Well, it does because we do have some therapies. And while it may not matter as much in a typical respiratory virus season for mild illness, where someone can take a day or two to recover and start feeling better within a week to 10 days without medical care, for those who require therapy, we do have some antiviral agents that are effective against influenza. And in a typical season, in the outpatient setting, many providers, either over the phone or after evaluating their patients, will prescribe one or more or one or another of these antiviral agents to combat influenza. Sometimes this is even done what we call empirically, without a test to determine whether it's flu or some other respiratory virus. And this is done particularly when the numbers of influenza cases are quite high, and the likelihood when someone presents with an ILI, or influenza-like illness, the overwhelming conclusion in that case is that it is most likely influenza, and a prescription can be given for an antiviral. Unfortunately, this year, we are going to be in a much different situation for two main reasons. One is the treatment reason that I just mentioned. So in order to make that decision about an antiviral that is effective against the influenza viruses, or some of the new therapies that are now becoming available for the SARS-CoV-2 virus, we need to know which virus someone has. And so one main message I would like to share with everyone today is that we all are going to need, whether it's medical providers or individuals in the public, to deal with respiratory symptoms in a different way than we usually do in a respiratory virus season. What do I mean by that? I mean having conversations with our providers and seeking out testing for any respiratory symptoms that seem to indicate a respiratory illness. As I mentioned, we typically don't do this because you might empirically be able to have a conversation and make some assumptions. This year, we can't do that. In addition, both the influenza illness and COVID-19 has a large proportion of people who can have very mild illness and even the asymptomatic illness. And so another message is that really, again, we need testing and conversations to evaluate even mild respiratory symptoms. And that's because in the setting of COVID-19, we really need to focus on quarantining and contact tracing in order to get the pandemic under control. And we're going to have to do that in the setting of these other respiratory viruses that are going to begin to circulate. So I mentioned symptom overlap. And we already are used to dealing with this, knowing that most respiratory viruses can cause a very generalized syndrome of headache and fatigue, muscle aches, just general feeling of malaise, and then also, of course, respiratory symptoms, so sometimes sore throat, cough, shortness of breath. And so those symptoms alone are not going to tell us the etiology or the type of virus that is causing the disease. Thankfully, diagnostic platforms are being developed as we speak and are available in some cases so that we will be able to take one sample from patients who develop these types of symptoms and test not only for COVID-19, like we've been doing for the past several months, but also for other respiratory viruses from that one sample. So we really are looking forward to that capacity, and it's an extra nuance that needs to be added to our testing discussions that we are having right now of making sure that testing is widely available, distributed in an equitable way so that communities who are most vulnerable to the severe consequences of either influenza or SARS-CoV-2 will be able to get that test and get the treatment that they need and the evaluation that they need. The platforms, well, I can say the platforms are available. I don't have the information for you about how widespread their availability is. So I think that's something we need to really watch in the coming months. They haven't really been implemented yet because we're not quite into flu season. We haven't started to see sustained transmission of influenza. But when it comes, it usually escalates quite quickly, similar to what we're seeing right now with SARS-CoV-2 escalating so quickly in so many different geographic areas. We're not sure exactly why this happens. We think it's related in some cases, in some degree, to temperature and humidity, and those factors that are favorable to the virus itself, lasting perhaps on surfaces and in the air, but it also has to do with our own behaviors. And when the weather turns colder, we come inside, we have more gatherings indoors, and are in closer proximity, and just the conditions that help help viruses transmit from person to person, and they're very unhelpful to us, of course, as we are trying to interrupt that transmission. So again, I just want to emphasize that the testing recommendations will be very different this year. We really want everyone to take respiratory symptoms very seriously and get evaluated for diagnostic reasons so that we can make the right treatment recommendations, but also so that we can get the COVID-19 in particular under control through quarantine and contact tracing. I mentioned treatments, and I'll just briefly touch on the fact I won't go into a long description of the treatments that we have on the inpatient side, but in addition to the antivirals that are available to outpatients who are not sick enough to need hospital admission, if they have influenza, they can get those antivirals against flu. And we are beginning now to have outpatient therapies for the first time for COVID-19 as well. So the monoclonal antibody therapy that was just granted emergency use authorization is indicated as a one-dose treatment for certain patients in the outpatient setting. And healthcare systems across the nation are working to implement now infusion centers for patients who test positive for COVID-19 and meet the treatment criteria, which in general is that they are in one of those higher risk groups to progress to severe disease that might need hospitalization. And so that is a major advance that has just happened recently of having those monoclonal antibody treatments available and for infusion therapy of outpatients. Very excited about that. Of course, I would be remiss to not mention the flu vaccine, and I'm going to defer to my colleague, Dr. Tan, who's going to speak extensively about flu vaccine. So I won't belabor that point, except just to say that it is part of what we need to be focused on right now. If anyone has not gotten their flu vaccine, it is more important than ever. We always recommend flu vaccine prior to the respiratory virus season, but this year it's more important than ever, and you will hear from him why that is and a lot of the statistics about it and the ways that we are approaching flu vaccination this year to get it to everyone. And of course, we know that we have good news that has come recently about vaccines that may be available soon for COVID-19. And that is tremendous news and something that gives us hope that even though we're entering this dark period of surge and such a dangerous time ahead, that we really have a light at the end of the tunnel with vaccines that appear to be highly effective based on the early clinical trial data. So we're very hopeful about that and already taking steps to put the infrastructure in place to disseminate and administer those vaccines. I'm sure that everyone has heard that there are a lot of logistics challenges to the COVID-19 vaccine, that it needs cold storage, and some of them super cold temperatures, and that is a challenge at scale to be able to freeze vaccines and distribute them and keep them cold and administer them to everyone who needs them. There's also a lot of work going on behind the scenes for prioritization planning, because initially we won't have enough for everyone to become vaccinated, and we are doing our best to make equitable decisions, making priority frameworks so that we can get the vaccine into the patients and the people who are at the highest risk of coming in contact with COVID-19 and also of having severe consequences if they do contract the illness. I want to say something about holidays, because in addition to heading into the respiratory virus season, unfortunately, we are also heading into holidays that are traditional times to gather with family and friends and to have the kinds of indoor dining and party atmospheres that are such a high risk for COVID-19 and also for other respiratory viruses to be transmitted. So unfortunately, this year, the safest thing to do is to completely defer those kinds of parties and gatherings and travel and celebrate with your household members. So those people around you with whom you've already been sheltering and in sort of a bubble. And to really minimize the gatherings around the holidays. Try to find other ways to reach out and connect and celebrate. And we all recognize how difficult that is, how risky it really is from a mental health standpoint, too, for social isolation. So we really need to be very thoughtful and don't say this lightly. But given what we're seeing in this country, we really need to take those steps. In addition to the holidays, we have a lot of colleges and universities and schools that are thinking of sending or are sending their students home for around Thanksgiving and then through probably around January that they're aiming to bring them back to campus. And so testing and quarantine needs to be part of that process. To avoid the kind of mixing between different geographic areas. We have such widespread transmission of the SARS-CoV-2 virus right now. It's a very high-risk situation, particularly if we bring people from different geographic areas and then are in a household close contact situation, either for the holidays or because of travel and students coming home. So please be very wary of that. So I said a lot of bad news things. I want to share some good news with you, and that is that the same interventions that we have been touting and pushing and trying to disseminate for COVID-19 to flatten the curve and prevent transmission of the SARS-CoV-2 virus also work for influenza and other respiratory viruses. So the good news is it's a package deal. If we do all of those behaviors, if we avoid gatherings indoors, wear our masks, do physical distancing so that we maintain 6 feet between ourselves and others, practice good hand hygiene, and really try to limit our contact with others, particularly indoors, we will save ourselves from all those viruses. And we know this, both from the science around those public health measures and also from data from the Southern Hemisphere, where we see many examples of countries who have controlled the COVID-19 pandemic and also have benefited from very minimal cases of flu and other respiratory viruses. So that's the good news. Of course, that's a two-sided coin. And right now, we are not controlling SARS-CoV-2 or COVID-19 in our country. And that's what scares me. It scares all of us in the healthcare system, knowing that surge that I described when I began speaking, that we see every year, is really at risk of having an enormous wave on top of it of the COVID-19 patients who need care. And we are already beginning to see that overwhelm hospitals and health systems so that patients, in some cases, need to be airlifted to other hospitals and health systems, and in tragic other cases, die without receiving the care that they otherwise would have received. So we all need to work together. I know we can do this. In our hospital and health system and at Johns Hopkins Medicine in Baltimore, Maryland, we have been saying we need to be surge savvy, assume everyone has the virus, and act accordingly. I'll stop there, and I look forward to your questions. Thank you.
Thanks so much. Go ahead, Dr. Tan, take that from here.
Thank you so very much for this opportunity to present to all of you. I'm going to try to speed things up just a little bit and give us some time for questions here. So just to remind everybody that we do have a new Healthy People 2030 objective for influenza. And this is for everybody 6 months of age and older, and the target is 70%. And remember, the previous Healthy People 2020 objective broke it up into multiple age groups. I do think that this target is interesting because I think healthcare worker rates should be a little bit higher than 70%, but I think we can debate that all day. But just to remind everybody that we do have this new objective. I'm going to show you some coverage data just to remind us that we are not where we want to be, even with the 70% coverage rates. With pediatric immunizations, we're sitting at about 63.8%. This is from the flu season that we just came out of. It's improving thanks to the wonderful providers out there, but we still need to continue to get better with our children because we still suffer some pretty severe mortality rates as a result of under-immunizing our kids. This is our adult influenza vaccination coverage, I guess to show us all. That's, again, only 48.4% of all adults 18 years of age was vaccinated with the flu vaccine last season. This is the season we just came out of. And significantly consistent with some of the points that have been brought up by previous speakers, only 69% of those over 65 were vaccinated. Only 50% of those between 60 and 64 years of age was vaccinated. And only 42.3% of adults 18 to 64 years of age were vaccinated. And significantly, in that age group, only 51% of those with high-risk conditions were vaccinated. I bring this up because I will bring this up again later on with this concept of the overlapping risk conditions between COVID-19 disease and influenza infection. And I think this is one of the reasons why we are so much focused on influenza and getting that off the table this upcoming flu season. I think I'm going to spend a little bit more time on the vaccine itself, but I'm also then going to actually kind of show you how we're trying to improve influenza immunization coverage rates with some of the campaigns that have really kind of been launched this flu season. So stay tuned for that. Pregnant women, as we all know, is a high-risk population for complications if they catch influenza, not just for themselves, but also for their developing fetus. The good news is the season that we just came out of, we were at 61.2% vaccinated. And what is remarkable is that with pregnant women, we need to make sure that we keep giving them the recommendation to get vaccinated. I note that on this slide, I show you that 21.3% of pregnant women who reported visiting a physician did not receive a recommendation or an offer for flu vaccination. And that's on us. I think we need to do better because we now know that with We now know that with pregnant women and in general, the recommendation by a provider is the number one reason why a patient gets vaccinated. So this slide shows you essentially of the women that did get vaccinated, what was the percentage why they got vaccinated, right? So if you take a look at the left bar, if a pregnant woman got a recommendation and was then offered or referred strongly for vaccination, maybe because the OB-GYN did not carry the vaccine, 75% of those women ended up getting vaccinated. On the other side of this graph, if the pregnant woman received no recommendation whatsoever, only 20.6% of them got vaccinated. That repeats the number that you just saw beforehand. So clearly, it is essential for us as for all healthcare providers to be recommending the flu vaccine to our pregnant women and to all our patients. Some final thoughts that I just kind of summarized on this slide. While we see some improvements in coverage rates for adults, it's still too low. We see steady improvements in the pediatric population, so I give it a little smiley face there, but I think we still need to do better. Our coverage in the 65 years and older population remains poor, so you see the little frowny face. I want to turn that into a smiley face next season. And the coverage in those high-risk adults are unacceptably poor, and that's that overlapping risk population with COVID-19. Pregnant women is improving. That was a 7.5% increase from last year. So I think that's really, really cool. But in our healthcare worker immunization coverage, where a lot of our facilities now actually have condition of employment requirements, those coverage remains very, very strong, except in long-term care facilities, where we maintain about a 69% coverage rate, and that's not acceptable because obviously in long-term care facilities, we have our most vulnerable patients. So I think one of the things that's already been mentioned, and I'm going to put this slide up again, this is from the season that we just came out of. This is the benefits of flu vaccination. One of the things we talk a lot about is people keep thinking about how vaccine is not effective, or we hear these numbers of 40%, 50%. And I remind everybody that those numbers deal with percentage effectiveness in preventing primary disease. That's great, but we need to remind everybody that flu vaccination does a lot more than just preventing the primary disease, which you see on the left-hand side. It prevents hospitalizations, it prevents mortality, and it also prevents severe illness. And I think we want to make sure that we broaden the concept of how effective flu vaccine is actually in terms of averting some of these negative outcomes beyond just incidence of disease. So just to remind everybody, in the United States, this is very unique. I talk to Europe and I talk in Asia as well, and we're the only country that has a recommendation that essentially says everybody gets vaccinated, which is really, really nice. The ACIP recommendation is here. As we do that, we just have to keep in mind that even though we want to vaccinate everybody, we still need to focus on some of those high-risk populations that we know will pay a consequence if they don't get protected. So just to remind everybody of the ACIP recommendation here. So what to expect this upcoming flu season? Well, I think if I had a crystal ball, I would still probably crack the crystal ball because I don't think we really know. But there have been multiple people with multiple chains of thoughts, right? So some folks have said there might be less flu than usual because of our social distancing measures. I doubt that. And the reason I doubt that is because we're seeing SARS-CoV-2 circulation jump up. So if we were adequately and compliant to social distancing and staying at home, we would not see SARS-CoV-2 jump up as quickly as it is. And because it is jumping up, I can only say that influenza is likely to jump up as well. So I don't think we're going to block influenza. So I think flu viruses and SARS-CoV-2 viruses, which obviously causes COVID-19, will likely co-circulate. And if they co-circulate, we're likely to see co-infection with both viruses. And as already has been mentioned, I'm not going to belabor this point, that creates that surge capacity issue, right? So surge savvy, as was said earlier, I think we all need to be surge savvy, including our public. That, you know what, presence of SARS-CoV-2 and influenza at the same time will place a tremendous burden on the healthcare system. And we need to therefore, like I like to say, hashtag avoid the twindemic, hashtag take flu off the table. We need to take it off the table. And that's for many reasons, including what I've already mentioned. This overlapping high-risk conditions of flu and COVID-19 makes it very critical. We don't have a vaccine against COVID-19 yet, but we sure as heck have a pretty good one against flu. So let's take flu off the table because we have these overlapping risk conditions of obesity, diabetes, cardiovascular disease, and age that we want to make sure that we can take flu off the table, at least for those populations. Again, we have that surge capacity issue. But what we do know is that if we can come out, all of us, with a strong, unified message that we have to protect ourselves against flu, even as we are sheltering in place, we can actually increase vaccination coverage rates and we can actually reduce disease. Australia and the Southern Hemisphere countries, as has been mentioned by Lisa, had dramatic success from the past flu season. Remember, they're in the Southern Hemisphere, so the flu season is our summer, so they're just coming out of it. So Australia, with a strong message about seeking flu vaccination, saw a 32% increase in their flu vaccination coverage rates to 86% of their population. Their shelter in place, as we know, they were a very compliant population, and because of that, plus the shelter in place, they saw a 99.5% reduction in flu incidence this past flu season. So essentially, they eliminated flu. So I think we can get close. I don't think we can get there, but I think we get close. So we need to make sure we do this unified messaging strong and powerful, and we depend obviously on all of you to do that. Vaccination efforts, however, as we ask people to come out, we need to make sure they feel safe. So we need to make sure they feel protected against COVID-19 disease. We need to make sure our access points, as we ask more people to get vaccinated, they should be able to get vaccinated at multiple access points, right? So therefore, we need to improve and increase the variety and the innovation around our access points. And finally, we need to extend our flu vaccination season. We cannot let people just stop getting vaccinated at the end of Thanksgiving. We need to think about how we can get people out and continue to vaccinate. And so I'm going to just show you some myths and questions about flu. I'm not going to spend a lot of time on that, but this resource is available to everybody on the IAC website as well as on the Immunization Manager's website. Happy to share that later on. But I want to kind of just quickly run through some of the resources we've now put together to help people get flu vaccine. IAC has developed a mass immunization clinic resource repository. This is where you can go to find out the best practices to run a mass immunization clinic. a drive-through clinic, a curbside clinic, a parking lot clinic, all the different ways we can get people consulted by telehealth, for example, and then getting them to get vaccinated and then sending them home quickly. So that's the URL. Please take a look at that, and we continue to gather resources for that. We also have a resource for those over 65. If you are looking to get vaccinated and you are looking for ways to get help to do that, we have a resource for that. And then there are multiple campaigns that I'm going to wrap up with by telling you about. I'm not going to spend a lot of time on this because there are a lot of them this flu season, and I like that. So as we all know, every year we have National Influenza Vaccination Week. It's December 6th through 12th for this upcoming season. This is sponsored by the CDC along with the summit that I co-chair with the CDC. This is to remind everybody that after Thanksgiving, we still want to vaccinate. Hence, you see the December date. I love this program from the National Foundation for Infectious Diseases. If healthcare workers don't get vaccinated, it's very hard for that healthcare worker to promote flu vaccine, right? If you're a healthcare provider that smokes, it's very likely you're not going to talk smoking with your patients. So same thing here, leading by example. So what we have here is, if I can get this to pop up, this is Dr. Fauci with his mask on, having got his flu vaccine. So leading by example, I think this is very, very important. There's a program from the AMA, the CDC, and the Ad Council called No Time for Flu. This program focuses on the high risk and minority population. You can see that up here. There's a program from the American Hospital Association that's targeted to healthcare workers, United Against the Flu, getting them vaccinated. There's a program from the American Lung Association that highlights high-risk adults. In this case, this gentleman has heart disease. So it says, don't let flu complicate your heart disease. This program is called My Shot. And there's a program from the American Nurses Association that highlights the need to improve our coverage rates because we're expecting 200 million flu vaccines available this season. So it's called the Race to 200 Million Flu Shots. So again, this idea of getting our coverage rates to where they should be so that we can hashtag take flu off the table. So I showed you a lot of stuff, but I put this slide up last because this is to remind us why we want to put ourselves out of business. These are all folks that have passed away from influenza. They cover every age group. We do not want to see these slides for next season. So I hope that we can take flu off the table this upcoming flu season. So thanks a lot, Bar. I'm going to turn this back over to you.
Thank you so much for that. And thank you, everyone, for helping to frame this issue. I would like to just start with a couple questions. And one is, what do we know about the flu vaccination coverage rate now? I know we have last season, but what do we know about where we are right now? And then the second question, I'd like all of you to weigh in on this. What would be your recommendation for story ideas for us on how to cover this? Because there's obviously a lot out there. The election news, I think, has taken up a lot of kind of people's interest. And so, you know, how can we as journalists talk about this topic in these coming weeks?
I'll tackle the coverage question first, and then maybe everyone else can jump in. So there is a lot of interest in real-time flu vaccination coverage rates. Unfortunately, it's a little harder to collect than you think. The CDC is working on some processes to work that out, and maybe with some of our COVID-19 programs, that might actually bleed over into flu surveillance, flu vaccination surveillance in the upcoming flu season. But right now, there is no official way to look at flu vaccine coverage in real time. But there are ways to check. One of the ways is looking at how much vaccine gets ordered, right? And then we can also check as claims data, but claims data has a lag of about a month or so. But if you look at those two, we're doing really well this upcoming flu season.
What does really well mean? What does that mean?
So we would say we are ahead of where we were last year. But again, we don't have real-time coverage surveillance. And I know the CDC is aware of that weakness, and they're trying very hard to create some systems to look at that.
Got it. Okay. All right. Thanks. Go ahead, Jenya.
I'll weigh in on that. You know, I think that the topic that I talked about in terms of disparities, I think a lot of that has fallen off the table. I don't hear a lot about the disparities with respect to even COVID-19 now. As you said, there have been a lot of things that we've had to focus on between August and now. So I think with respect to journalists, to bring that back to the table, to bring that on the forefront, to let the population or let the public know about the disparities with respect to influenza vaccine and COVID-19. So I just think bringing that back to the forefront would be something that would be important.
And I would add, and you probably detected it when I was speaking earlier, but we've tried to shift our message a little bit away from telling people the individual things to do. So wear a mask and physically distance and wash your hands. We're still saying that, but I think it's important to empower people to know the why behind that. There's so much misinformation out there. Many people in this country are hearing that it's a hoax and it's not a problem. And so the more I think that we can use patient and family stories to make it very real and individual so people can really relate to it. The numbers are so high now, tragically, that they're almost difficult to relate to and to even wrap your mind around what does that mean in a community or to a family. So a lot of people are doing this, but I think patient stories are very powerful. And then rather than, it's a subtle difference, but rather than saying, here are the things that you must do, shifting the language to say, assume everyone has the virus. We have it so widespread now. Assume everyone has it. What would you do to protect yourself? And then the person comes to the conclusion themselves. They need some personal protective equipment. They need to distance themselves from that person at the grocery store, et cetera, if you're assuming that everyone has the virus. So just a thought.
One more thought that I had, I think we need to also start building trust back because, now that the election is over, and I keep saying election because a lot of that has had to do with the political aspects of COVID-19 and maybe even influenza, we're going to have to start building trust back even within our major our governmental bodies that are sending the message out about flu vaccination. I think the public's confused, healthcare workers are confused, everybody's confused. So we need to figure out a way to build trust back in this country with respect to, even if you're talking about science, who to believe and who to trust. So I think those kind of things we need to start back with that.
And I think along the idea of human interest stories, I really want to, play on this idea of surge capacity as well, because I think that's a community responsibility. Sometimes we think, hey, it's okay if I get sick, but if you get sick and you make someone else sick and someone else goes into the ER and surges the ER, you can actually impact the care of other people who might desperately need medical services, right? And I think sometimes we lose that. The example I'm going to give is the story of someone who ended up passing away just recently from colorectal cancer. And this person actually had symptoms right around the turn of the year that presented as lower back pain. And this person said, it might be a sore back. And then, when it got to the point where he thought he should go in, it was COVID. And there was surge and there was everything going on. And he said, you know what, I'm going to not go in because the surge is too much. And then as a result, he deferred care. And then by the time he finally did get care, it was a little too late. Not saying that it would have saved his life, but I think there are multiple examples of these human interest stories that might help folks understand that it's not just about them, but it's also about the community they live in.
Okay, thanks for that. Virginia, a question about just the messenger. What kind of messengers would be ones that could reach minority communities? I mean, who are you thinking of? And I think that's because I've definitely heard that, the message, we need to work on the message.
Yeah. Well, I am, as an infectious disease specialist, have been watching this, and I watch news media, and I watch the messages that are put out there. And again, I think, as with anything, you have to have somebody at the table that looks like the people that you want to represent. So I'm specifically talking about more messaging from minority physicians who are in infectious diseases and public health. The Infectious Disease Society of America, we just formed a subgroup, an sub-organization called the George Counts Interest Group. And there are about 60 of us that are infectious disease specialists all over the country. You know, if you don't know where these people are, then you don't know where you don't have a pool from which to pick. So with respect to the message, I think a lot of people that look like me, a lot of people who are from the minority community who are experts, also experts in the field, might be helpful. I know that a lot of my friends and acquaintances and so forth look to me and say, well, you know, Dr. Banks, we want to know what you think. And I think that's important because there are many of us that are out there that are minorities that are qualified.
Do you guys have thoughts on that?
I would also mention public-private partnerships that can be so important, so that you have the medical experts partnering with community leaders, community organizations, and doing outreach, and being informed by those community leaders about the types of messages and the types of delivery, the venues. There's just those partnerships, I think, are very powerful to get messages out and also deliver services.
And access. We need access points for communities in rural areas. So we're not just talking about ethnic and racial minorities. We're talking about socioeconomic and the disparities as well, right? So access in rural areas is something that we always are challenged with. So I think all I can say is we need to think broader. You know, when I talked about drive-through clinics, what if you don't have a car? So those are things that we need to be really thinking about as well.
Good, thanks. I'm going to start to go through some of the list of questions. And by the way, there's a box that audience members can type in their questions. So one of the questions we had here is, how does COVID-19 affect the pursuit of the universal flu vaccine? Is that something that any of you can speak to? Lisa, is that something, what we know about where we are with the universal?
I'll jump in because I follow this on the policy level.
Yeah.
Of course. I don't think it's going to impact it dramatically. I think there's a lot of parallel work that's going on flu vaccine development. I think there's really a lot of advancement. In fact, some of the vaccines that you're going to see coming out from Novavax and Medicargo are based actually on their pursuit of a universal flu vaccine. So it's actually feeding the other way as well. Universal flu is fed into COVID-19. So I don't think there's going to be a dramatic impact. I mean, there might be a delay while some of the resources have been focused on COVID-19, but I think we're going to come out of that as well. I think the bigger question is what is a universal flu vaccine, right? I mean, I think if we're looking for that one shot 10 years, we ain't going to get that. So I think we're going to have to think about what we consider to be the universal flu vaccine. Will we accept one shot that will last us 3 years? Will we accept 2 shots that will last us 5? I mean, the FDA actually does have a guidance on what they want to see as part of the outcomes for a universal flu vaccine. So I think we need to think about those questions a little bit more as we talk about universal flu vaccine.
And could any of the new technologies that are developing be used towards this universal flu vaccine concept? Do you know?
I'm not sure. Well, I was just going to say I'm not sure about universal flu vaccine per se, but I do anticipate, especially if they're highly successful, that we will see this new type of vaccine being applied to other pathogens, particularly given the efficacy that has been reported so far. Although there are those logistic challenges to this type of vaccine as well.
I have to say that the data from the 2 mRNA vaccines have been very striking, because I remind all of us that we've actually been pursuing mRNA technology for at least 10, 15 years now, but this is the first time it's been used in vaccine development, and they have developed vaccines for it, but nothing has gone to licensure. But this is the first time. And this 90+% efficacy, is very optimistic for the technology. And I think we will see the use of this technology in other vaccines, including potentially a better flu vaccine.
I'd like to go to just talking about the COVID-19 vaccine potential. What do we know based on the challenges of flu vaccine and messaging? What does that mean for COVID-19 vaccination and the challenges that are going to be there for that, and messaging and misinformation? And can you speak to that?
Well, just briefly, vaccines are great, but vaccines don't prevent anything. Vaccinations do. So, as I have mentioned, we're going to have to do the technology and all of that is great, and the numbers sounded fantastic. But I think we're going to, I believe, and I know that, again, as has been mentioned, actually Pfizer has reached out to a number of organizations to try to tackle this topic of building trust and sending messages out about their vaccines. So, yeah.
But what about the ability to distribute? The Washington Post actually had a story today about lessons learned from the 2009 swine flu pandemic and what was learned and what has not been implemented. That included challenges with messaging and then also the ability to distribute the vaccine. I understand the Defense Department is got a plan, but I wanted to know, do you have any sense of where things are with that and what the distribution plan is?
So I think following Operation Warp Speed and trying to coordinate that with what we know, I think this is the challenge for the last couple of months: is how is Operation Warp Speed leveraging existing information that we learned from 2009 H1N1. And I think there's a lot to be said about not creating redundant systems. So you've heard of systems such as the VAM systems, the Tiberius systems, all the different things that have come out of Operation Warp Speed. When personally, in my opinion, there's probably an existing infrastructure with immunization registries that could have been probably leveraged and developed further, that would have not therefore required all these redundant systems to be put in place. But my position now is that since we did put some of these things in place, at the end of this all, we probably will be out of this by next summer, considering the fact that we're probably going to have multiple vaccine manufacturers with highly effective vaccines. I think we need to then think about, and this may be a story, about how we then take these systems that we have now developed for COVID-19 and making sure they get wrapped back into our existing infrastructure, so that we don't lose the investment that we've already put into them, and so that we can use them, because we know that our immunization registries, especially with adult information, is still very, very poor. So if we capture 150 to 200 million adults through our COVID-19 systems that we're now building, let's not lose them. Let's make sure we get them back into the immunization registry so that we don't have to worry about this for the next pandemic.
And I would say that lessons learned applies across the board. We are living through a historic response to a devastating pandemic that previously has only occurred every 100 years or so. So we really do need to leverage all of these different things and the things, learn from the things that have not gone well. But the things that have gone well, we need to capture that. I'm thinking about our own hospital and health system, our surge capacity planning, air handling modifications in our buildings, the lessons learned about personal protective equipment stockpiles, and particularly I would mention staffing, because it's such staffing shortages are the biggest threat that's facing us right now in healthcare. So there's just so many lessons learned and so much to do to bolster our preparedness going forward, so that we take all of this that we have put into place and institutionalize it. Don't forget it. Save it for future generations, but also build in the resiliency that is needed.
Yes.
I would point out, however, also that some of the lessons that we've known about for years, like this issue with lack of access to health care, the issues that you mentioned with respect to, what if you don't have a car? These have existed for many, many years, for decades. We've known about this. So I guess I would question about lessons learned and what we do about them. We still haven't done anything about them. And we're still here in 2020. We're still in we knew about this I've been practicing medicine for a very long time, and we've known about this. So I'm just not so sure what we do about lessons learned, because we still haven't fixed the problem. And those issues of structural racism that I talked about still haven't been fixed, which is why we're probably in the similar situation that we're in now. So we haven't really dealt with the root cause analysis of a lot of this so that a lesson can be learned and can be changed.
I totally agree. I have to say that one of the challenges of trying to address systemic racism at the federal or national level is that we don't see all the gaps. I mean, it seems very disconjointed to at that higher national level. I think a lot of the biggest changes that we've been successful with regards to disparities and social economic disparities actually have occurred at the community and regional levels. And so the question is, how do we fund resources so that the states, the regions, and the local communities can do what is necessary to make those changes and share those best practices at a federal level or a national level, right? I think we haven't, and I agree with you, Virginia, we haven't looked at it at the root level, and I think we are afraid to. And I think because of the enormity of the problem, right? And I think we need to.
I completely agree, and I think that this is an opportunity. The confluence of the events over this year has really shown how interrelated everything is. And right, Virginia, we have known and we have seen this for so long, but I think the virus has shone a light on all of it in a way that is inescapable. And so now is the time to seize that spotlight and to address it finally.
Do you have any sense of the President-elect's coronavirus task force that might be addressing these points that you're just talking about in terms of disparities, but also, I mean, again, back to sort of the flu and messaging and how do we reach communities for not only the flu, but COVID-19 and other health issues? Have you been in connection with any of the folks? Are you engaged with that task force?
I am not. I know several people that have been appointed to the committee, but it's still very new. The individuals that I know that are involved seem quite capable, but I don't know yet. It's just very, very new. But I do know that they're reaching out to the communities to try to, get with organizations, minority organizations particularly, to try to help this whole situation. So I do know that they're involved with that.
Same answer with Virginia Barr, but one thing I'll point out is CDC, I think, has already put into place, and they're looking to launch a new strategy called the Vaccinate with Confidence strategy, which is focused on COVID-19 vaccinations first, but I think will be very applicable, obviously, after COVID-19 vaccines for all other vaccines as well. They presented that actually at the ACIP meeting on October 30th.
Got it. I mean, there was a question, and this is somewhat related to this, which is, how does this pandemic influence discussions on universal health coverage, especially with a new administration in the U.S.? So the question about that. I know that's not necessarily your expertise, but somewhat related to what we're talking about in terms of access and how do we change systemic problems in our healthcare system?
Well, I mean, this also goes to political determinants of health. It's who you vote for and who is put into power. And so now we have a Supreme Court that might not be, exactly favorable to a lot of these things starting at the top. So, and as I mentioned earlier, we have, I think it's still, you guys correct me if I'm wrong, 14 states that still haven't done Medicaid expansion. And you have to look at who's leading those states. So, I just don't know.
Yeah, I think that's a really good point about Medicaid, because obviously Medicaid is one of the primary funding sources for preventive care and obviously immunization. And there's a lot of challenges with getting providers paid through Medicaid, not just in terms of reimbursement for the vaccine itself, but reimbursement for the cost of giving the vaccine. And so we know they're working with a very small pie, and that pie doesn't change. So when you make a slice bigger, you make another slice thinner. So it's a huge challenge with Medicaid. I think to Virginia's point, the lack of expansion in some states is challenging. And then I also remind us all that in some states, and I don't know the number for this, they might have expanded Medicaid, but they may have grandfathered in the traditional Medicaid, which means therefore they had actually a two-tier system of Medicaid within their states, right? So a lot of that we hope will be addressed if we can keep the Affordable Care Act, because I think there are ways to address that. I think that's my hope for the future.
Okay, we're going to go back to. Oh, go ahead.
Oh, I'm sorry. I was just going to add that prevention is such a big piece of this. So we've talked about access and and social determinants of health, but it's just incredibly important that we also shift our focus to prevention. Again, the virus, sweeps through, and in and of itself as a pathogen should not have affected one individual differently than another, but we see how it's shining a light on all of the underlying conditions. If we could do a better job of prevention and treatment of those, or even preventing them in the first place, then we would be less vulnerable as a population.
Go back to just some more questions about COVID and the flu. So we have some questions like some experts say we need to learn to live with COVID-19 like the flu, so it will be continually circulating. Going forward, can you comment on what that would mean and what that would look like? And then if someone has COVID or suspects they may have it, is it safe to get a flu shot?
I just read about that today. Now, I stand to be corrected, but the answer was no, that you need to wait at least until you test. Please correct me. I just read about that this morning.
You're right, Virginia.
That the answer is no, that you should wait at least until you're negative, and then some days after that. So that's the most recent information that I looked up this morning.
So Virginia's right. CDC has guidance on that. You defer someone who's COVID positive from flu vaccination until the standard guidance for when that person can come out of quarantine or isolation if it's a suspected case, obviously. Then you can give the flu vaccine. It has nothing to do, but to be sure, it has nothing to do with the fact that that you can't vaccinate someone who has got mild illness. You can, absolutely, you can vaccinate someone with mild illness. This is about protecting the healthcare worker.
And what would it look like if COVID-19 and influenza virus became the circulating as flu viruses are now? What would that mean? A lot of shots?
I'll leave it to Lisa. She's our ID, Lisa in Virginia.
I would say we may end up in that kind of a situation where it's still continuing to circulate year after year, but hopefully with a vaccine and treatment so that it doesn't have the devastating consequences that it is currently having. But I would also caution against that approach now, because we have so many vulnerable people. We are not yet in the position of having the vaccine and treatment. And the other thing is that this is not just a respiratory illness. So we've been talking primarily about respiratory virus season right now. And we know that it does kill some people through pneumonia, but there are a whole host of other organ systems that are affected by this virus. We don't yet fully understand the long-term consequences of the long hauler syndrome, of people who continue to have profound fatigue, neurologic symptoms, joint problems, heart involvement. So it is really a dangerous virus, and until we know more and have more tools in our toolbox, we need to be extraordinarily careful.
Great point.
I completely agree, and I think this is the conversation that's going around that is contributing to the not wearing of masks and all of the things that are contributing to this surge. And I hear this comment all the time, so I think we have to really push back on that, at least at this juncture.
Yeah, I can't believe the people who say this is not a serious illness, and I think unfortunately a lot of them are the younger adults who are out there in large social groups.
And I think, just going around, this quarantine fatigue is really, you talk about a surge with respect to COVID-19. There really appears to me to be a huge quarantine fatigue surge to the point of just a reckless disregard for anyone else health and even their own. So I'm happy to see the vaccine. I certainly would like to see more safety efficacy data, but I'm just saying this quarantine, we've got to, figure this out. This quarantine fatigue is just surging.
Any thoughts on that, LJ, on messaging for something like that?
I think we have to change the message, right? Part of it is, we've been saying, I think Lisa mentioned this, I think this is the idea of empowering someone to do something that resonates with them, right? So it can be, I'm helping my community, I'm helping my family, I'm helping myself. And I think it's so we still just say stay at home, for God's sakes, excuse the language. We need to change that messaging and make it about I'm staying home because I have the right and the choice to do that. I know it's hard. It's very hard, which is why we're surging. Because if it were easy, it would be done.
I mean, how much do we think this is politics? It's because of the politicization, unfortunately.
Well, I'll dash out there and say a lot.
Yeah.
Thank you.
It's a lot. And, you don't want to cast a wide net. You don't want to stereotype anybody, but it just sort of seems that sometimes the disregard for those public health plans or things that are already in place, they follow a certain political ideology like a shadow. So I think a lot.
So I also want to point out that there's been an alignment of the anti-vaccine forces with the anti-masking forces too, right? So this whole idea of personal autonomy, personal rights, personal choice made unlikely bed partners of these two groups.
Quickly, I know you have to go very soon, LJ. There's a question here about, can you have influenza and COVID-19 at the same time, regardless of age? And then what percentage of folks who are infected with the flu never exhibit symptoms but can be contagious, just like COVID-19?
Well, you've got two ID folks here. I'm going to defer to them, but I think the answer is yes, and a significant percent.
You mentioned yesterday that there were two folks that had passed away, I think, in one state that had both.
Correct. Idaho had first two flu deaths reported, and both of them were co-infected with COVID-19.
And is that an early indication that we will maybe see a surge of both? Yeah. I mean, I keep getting that question. I've been asked that a lot here. What do we know?
I hope. So if we do our flu vaccination right, if we do our social distancing right, I hope the answer would be we will be able to reduce that. But as I said when I presented, I said I fully expect there will be co-circulation of both, which means there will be co-infection. And there's already existing data from spring that shows that co-infection, with especially the elderly of both, results in actually severe, prolonged recovery and higher hospitalization rates. So that's data coming out of China. So I defer to the others here.
Did you want to weigh in, Lisa? Or?
Oh, I'm sorry. I thought Virginia was going to say something. No, I just second that. Definitely data showing that co-infection is possible. We know this happens with other viruses as well, and so there's no reason to think that it wouldn't occur this time. And that causes more severe consequences, as we just heard, and it's a real risk. Unfortunately, and it can also, even if you don't get them exactly at the same time, I think having one can set you up for other infections as it weakens and damages your tissues and sets you up to be more vulnerable for a second infection.
The other point that I think, LJ, you've often made is that the long-term effect of flu that it can have on heart challenges going forward. And I know that was a messaging kind of shift that the medical community was trying to emphasize, that this has long-term consequences to heart and other health issues. And I wonder if you could speak to that as it relates to us. So this seems to be the same thing with COVID.
Yeah, I'll speak to that, and hopefully that will tee off the other speakers on this as well. I think it's clear that there's a dramatic impact on acute influenza infection on both people with chronic diseases such as cardiovascular disease, diabetes. I think the data is actually accumulating, right? So I think it's clear that that's happening, and I think in addition to that, for those who are frail, I think influenza infection, because it's a pro-inflammatory disease, has a dramatic impact on what we call inflammaging, which is this idea of a systemic low-level increase in inflammatory responses as you get older, right? So I think one of the things that we talk about is this idea of taking flu off the table so that you don't actually decrease your quality of life. I think what we're saying is obviously with these vulnerable populations, it's about quality of life as well. The flu vaccine may not prevent you from getting flu, but if you have these high-risk conditions such as age, cardiovascular disease, it can prevent a knockout punch, or it can prevent you from become functionally disabled because of flu, right? I've used this saying before, Bar, you've heard me say this, if someone who's over 65, may walk into a hospital with influenza infection, but 3 weeks later may actually come out with a walker.
Because they've been lying down in bed for 3 weeks. Right?
Exactly.
Yeah.
And unfortunately, Bar, I got to go. I have another meeting in minutes. So apologies. What a great discussion, folks.
Thank you so much. We have 4 more minutes if Virginia and Lisa can stay. Yeah. Thank you so much.
Bye.
Thank you. And if you want to keep going with that, either Lisa, Virginia, on the long-term effects of the flu, and what we know about the evidence.
Yeah, I don't have anything really else to add to his comment. It did raise with me an issue with respect to, if I could just take that but go to another topic that's similar. It was my concern about the COVID, the Pfizer and Moderna COVID vaccines that are coming out. And with respect to me wanting to see more safety information, because as I was discussing this with some colleagues, it's not like we have a vaccination that we're getting ready to give to children, although clinical trials are going to be starting, or they haven't started yet, soon on children. But it's not like we're going to roll this vaccine out to children who don't have a lot of comorbid illnesses, who are not on a lot of medications, with cardiac disease and a lot of other underlying problems. We're going to be giving a vaccination to elderly people who have a lot of comorbid illnesses, who are on a lot of medications. And in terms of long-term effects, I know we will not have a lot of long-term data, but those are the kinds of things that I'm interested in seeing when we're getting ready to promote this drug to that high-risk group. And this is one of the things that I was sort of thinking about. This is a different. We're going to have to, see the target audience that we have right now could be significantly impacted if there are problems.
Mm-hmm. Is there something you want to add to that, Lisa?
Well, I would just add that in COVID-19 and some of these other illnesses, and influenza included, there are two things going on. There's the pathogen's effect on the body, and we need antivirals to, fight the pathogen itself. But then what we also see is the immune reaction and the effect on our patients, and that overly exuberant in some cases, immune reaction can in some cases cause more damage than the pathogen did itself. And so I think, along with what Virginia was saying, that, this is something that the clinical trials are monitoring, and we will need to keep an eye on, because it's that balance between fighting the pathogen and not having immune-mediated damage, which may be playing a role in some of this long-term syndrome that we're seeing after the viral infection.
Right. There's still a lot of questions about these vaccines and how effective they are and for how long, and, as you say, long-term impacts, which I imagine will affect the ability to message the rollout of the vaccine. Any thoughts on that?
Again, even in taking care of COVID patients every day, we were talking about, we're still learning new things. I mean, there's still new neurological situations that we're looking at in our patients, and we're wanting to know, has anybody seen this with COVID-19? Has this ever been described? We're going back to see if there's any, if there are any papers that have been written on this. So we're still learning a lot about the long-term effects of this disease. And long-term, we're acting like we're talking years here. We've only been in this in the United States, since February? And we're talking about old data. So here we are in November. I mean, we're still young into this disease, relatively speaking.
It's so true. And when we're asked how long immunity lasts, we can't know yet because it hasn't been long enough to know that.
Yeah. Well, I think we'll wrap up on that note. I know that, Lisa, that you are available to stay afterwards for some Q&A with folks. If there weren't any questions that they weren't able to get answers to, if they have questions that they get answers to, that they can speak to you. I think, Virginia, you weren't available to stay for that.
Yeah, I have to work.
Yeah, I understand. So thank you so much for taking all your valuable time. I know how so very busy you are. Thank you for being part of this discussion and helping our colleagues cover this obviously very important topic of flu and COVID-19. And I wish you a safe and happy, healthy holiday coming up. And to everyone else who was attended, thank you so much.